Imagine looking at a part of your scalp that appears almost empty. Under normal light, it looks as if the hair has disappeared. The skin is visible. The old density is gone. And the obvious conclusion is terrifying. The follicles must be dead. But place that same scalp under magnification, and the story can change. You may find hairs so short, pale, and thin that they barely rise above the skin. Some are producing fibers far narrower than they did years ago. Others may be sitting empty between growth cycles. The area that looked dead may still contain living structures beneath the surface. So baldness is not always a simple switch between alive and dead. It can be a slow biological retreat. And that creates one of the most important questions in hair loss science. Can a miniaturized follicle become strong again, or is there a point when recovery is no longer realistic? To answer that, we first need to understand what miniaturization actually is. The factory beneath your skin. A healthy terminal follicle behaves like a full-sized factory. During its growth phase, called anagen, it remains active long enough to produce a thick, long, pigmented hair shaft. Near the bottom of that follicle is a structure called the dermal papilla. It communicates with the surrounding cells and helps control the size of the follicle and the fiber it produces. A large, productive follicle creates a strong terminal hair. But in androgenetic alopecia, genetically vulnerable follicles respond differently to androgen signals, especially dihydrotestosterone, or DHT. Over repeated cycles, the follicle becomes smaller. Its productive growth phase becomes less effective, and the next hair emerges shorter, finer, and less visible than the one before it. A thick terminal hair gradually begins to behave like a tiny vellus-like hair. But here is the detail most people miss. The hair is not simply falling out and never returning. The entire production system is changing. The factory may still be present, but it has been downsized. Researchers have even suggested that miniaturization may sometimes occur in larger biological steps rather than through perfectly gradual changes. Histological evidence also shows that, in responding follicles, at least some of that process can move in the opposite direction. There can also be a longer delay between the loss of an old hair and the appearance of a new one. Researchers call this empty interval kenogen. During kenogen, the follicle remains underneath the skin, but there is no visible hair shaft occupying it. These empty periods occur normally. However, research has found that they can become longer and more frequent in androgenetic alopecia, contributing to the appearance of thinning even before every follicle has stopped producing hair. This is why two people can appear to have similar baldness while having very different recovery potential beneath the skin. One may still have thousands of weakened follicles producing microscopic hairs. The other may have much more advanced structural change, and the mirror cannot reliably tell you which one you are. The follicles that were not dead. For years, people casually described miniaturized follicles as dead. But one major study revealed a far more interesting reality. Researchers compared bald and non-bald scalp taken from men with androgenetic alopecia. They were searching for the cells responsible for regenerating hair. And what they found was surprising. The bald scalp still retained a population of hair follicle stem cells. The original biological reserve had not completely disappeared. What was dramatically reduced were certain progenitor cells, the more active descendants that help transform those dormant instructions into a growing follicle. Think of the stem cells as the original blueprints for a factory. The blueprints are still locked inside the building. But many of the trained workers needed to read those blueprints and restart full production are missing. That does not prove that every bald follicle can be restored. But it explains why the word dead is often too simple. In many follicles, the biological machinery may be impaired rather than completely erased. And we know that some miniaturization can reverse because researchers have watched it happen inside scalp tissue. The evidence hidden inside a biopsy. In one study, scientists took small scalp biopsies from men before and after 12 months of treatment with finasteride. They counted terminal hairs, the thicker, more developed hairs, and compared them with miniaturized vellus-like hairs. In the finasteride group, the average number of terminal hairs increased. The number of miniaturized hairs decreased. And the ratio between terminal and vellus-like hairs improved more than it did with placebo. This was not simply a participant looking in the mirror and saying that his hair felt better. It was histological evidence that some weakened follicles had moved back toward producing stronger hair. Another study produced an equally important clue. Finasteride increased total hair weight more than it increased the actual number of hairs. That means much of the visible improvement did not come from creating enormous numbers of new follicles. It came from existing hairs becoming thicker, longer, or more productive. And this matters because visual coverage does not depend only on how many hairs exist. It also depends on the diameter of every hair. A small increase in diameter can create a surprisingly large improvement in coverage. A hair shaft is three-dimensional. When its diameter increases, the amount of material inside that shaft rises much faster than the number on a ruler would suggest. Imagine replacing thousands of thin wires with thicker cables. The number of cables may remain almost the same, but the surface underneath becomes much harder to see. This is why a person can experience meaningful cosmetic improvement without suddenly growing thousands of completely new hairs. Randomized trials with topical minoxidil have also demonstrated improved hair growth in androgenetic alopecia over many months of treatment. But minoxidil and finasteride do not perform the same job. Finasteride reduces a major androgen signal driving miniaturization in susceptible male follicles. Minoxidil promotes a more favorable growth state through different biological pathways. One attempts to reduce the pressure shrinking the factory. The other attempts to make the factory more productive. But this still leaves the most important question unanswered. Why do some people achieve impressive recovery while others see almost nothing? Miniaturization is a spectrum. Miniaturization is not one fixed condition. It is a spectrum. At the early end, a follicle may still produce a pigmented hair that is only slightly thinner than the hairs surrounding it. The person may notice less volume, a wider part, a hairline that no longer looks as solid, or a scalp that suddenly becomes visible under strong overhead lighting. At this stage, the goal is often not to create brand new follicles. It is to protect and strengthen the large population that still exists. In the middle of the spectrum, the differences become easier to see. Some hairs remain thick. Others are short, pale, and wispy. More follicles remain empty between cycles. The scalp may look sparse, but magnification can still reveal numerous miniaturized fibers. These follicles may still have recovery potential, although they will not all respond equally. And full childhood density is rarely a realistic promise. At the advanced end, an area may have been visibly bald for many years. The follicles can become extremely small. Inflammation and collagen deposition can develop around them. And normal relationships between the follicle and its surrounding support structures may begin to deteriorate. Histological research has found that early androgenetic alopecia can involve follicular microinflammation, while more advanced cases can show thickening of the surrounding sheath, increased collagen, and parafollicular fibrosis. In some severely advanced cases, researchers have described complete destruction of affected follicles. A separate proposed model focuses on a tiny muscle attached to the follicle called the erector pili muscle. Researchers have observed that this attachment can become lost or severely reduced in androgenetic alopecia. Some scientists propose that losing this connection may be one reason advanced miniaturization becomes increasingly difficult to reverse. This remains a biological model rather than a simple clinical test, but it highlights an important reality. A follicle is not an isolated tube. Its ability to regenerate depends partly on the environment surrounding it. When those supporting relationships deteriorate, recovery becomes much less predictable. But there is no universal countdown saying that every follicle dies after exactly 3, 5, or 10 years. Age alone cannot provide the answer. And a shiny appearance does not automatically prove that every follicle underneath has disappeared. The best clue is not how frightening the scalp looks. It is what biological structures are still present. How can you tell whether recovery is possible? A dermatologist can examine the scalp using trichoscopy, a magnified inspection that reveals details invisible to the naked eye. In androgenetic alopecia, trichoscopy may reveal large differences in hair shaft diameter. Thick hairs sit beside much thinner ones. There may be increased numbers of vellus-like hairs, empty follicular openings, yellow dots, or pigmentation around affected follicles. This variation in diameter is one of the most useful clues that progressive miniaturization is occurring. When numerous tiny hairs remain, there is at least something for treatment to work with. That does not guarantee dramatic regrowth, but it is biologically different from an area where the follicular structures have been replaced by scar tissue. And this distinction is critical because not every thinning scalp is androgenetic alopecia. Sudden heavy shedding, sharply defined bald patches, intense scaling, redness, burning, pain, pustules, or a visible loss of follicular openings can suggest another condition. In primary scarring alopecias, inflammation damages the follicle and can replace it with scar tissue. Studies of trichoscopy have identified absent follicular openings, parafollicular scaling, and white scarring patterns as important clues to these conditions. Trying random growth products while an inflammatory scarring condition continues can waste the most valuable treatment window. So before asking whether the hair can grow back, the first question should be, what is causing it to disappear? What recovery actually requires? Once the diagnosis is correct, treatment has two separate jobs. The first is to stop, or at least reduce, the force pushing the follicle downward. The second is to encourage the weakened follicle to produce a stronger fiber. For many men with androgenetic alopecia, treatments that reduce DHT signaling can slow progression and improve growth. Controlled finasteride trials found that the treatment slowed hair loss and increased growth over 1 and 2 years. Longer-term research found durable improvements in men who continued treatment for 5 years. Growth stimulants such as topical minoxidil can also improve regrowth. But notice the time frames used in these trials: 24 weeks, 48 weeks, 1 year, 2 years, not 10 days, not 1 month. A follicle works in cycles. You cannot accurately judge a biological cycle using daily mirror checks. Early success may simply mean that the condition has stopped becoming worse. Visible thickening can take longer, and genuine improvement can be hidden by changes in lighting, hair length, camera angle, styling products, or whether the hair is wet. The most useful comparison is consistent photography and, when possible, a measured clinical examination. Not memory. And these treatments generally support hair only while they continue providing their biological effect. In an early study of minoxidil withdrawal, researchers found that the recruited hair growth was not sustained after treatment was stopped. The underlying tendency toward miniaturization had not been removed. This is why treating androgenetic alopecia is closer to controlling high blood pressure than curing an infection. It manages an ongoing biological tendency. It does not rewrite the genes inside the follicle. The word regrowth is hiding something. There is an uncomfortable truth that the hair industry often avoids. Regrowth can mean several completely different things. It can mean a miniaturized hair becoming slightly thicker. It can mean an empty follicle returning to an active growth phase. It can mean enough improvement across thousands of weakened follicles to make the entire scalp appear fuller. Or it can mean the complete restoration of a hairline that has been bare for a decade. Those outcomes are not equally likely. Clinical trials showing increased hair count, hair weight, or hair diameter prove that biological improvement is possible. They do not prove that every advanced bald area can be returned to its original state. When follicles are too structurally compromised to produce cosmetically useful hair, transplantation becomes a different strategy. A transplant does not awaken the original follicles. It relocates follicles from a more resistant donor area into the thinning area. And even then, the untreated native hairs surrounding those grafts may continue to miniaturize. Conclusion: can miniaturized hair grow back? Yes, but the answer depends on how far the follicle has changed. A follicle that is still producing a thin, weak hair may still have the biological machinery needed to produce a thicker one. A follicle that has remained inactive for years, lost its supporting structures, or been replaced by scar tissue may have far less potential to recover. That is why early treatment usually offers a better opportunity than waiting until an area appears completely bald. But there is no exact deadline. You cannot look at your age, count the years since thinning began, and know with certainty whether a follicle can recover. The most reliable clues come from the diagnosis, the condition of the scalp, the presence of miniaturized hairs, and how the follicles respond over several growth cycles. A miniaturized follicle is not automatically dead. It is a follicle producing less than it once did. Sometimes that process can be slowed. Sometimes it can be partially reversed. And sometimes the damage has progressed too far for meaningful regrowth. But understanding that raises another question. If some miniaturized follicles can recover, which treatments give them the best chance? And how do those treatments actually work? Because at HairLab Explained, every answer leads to a question. In our next video, we will compare the main treatments used to protect and strengthen miniaturized follicles, and explain which part of the hair loss process each treatment actually targets. Do they all create regrowth? Or are some treatments only slowing the damage while others stimulate the follicle? The answer may completely change how you choose a hair loss treatment. Subscribe to HairLab Explained and turn on notifications so you do not miss the next video. I'll see you there.